So a lot of us do joint replacement surgeries, and a lot of us tell our patients that you're going to be absolutely well, you're going to have no pain, you're going to run, you're going to do everything. But still, we do have a subset of patients that are not as happy as they want to be, and we call them painful total joint arthroplasty. So I'd like to thank Dr. Ashish, Dr. RN Singh sir, and the whole team of AMC, Sushil, everybody, for this wonderful hospitality here. I think I should call Patna my second home, thanks to them. So, what does our patient want? If you leave it to them, they'd want to be like this, jumping on a trampoline and sitting flat on a ground. So I call it the forgotten knee replacement. So what is the forgotten knee replacement? No pain, full range of motion, no swelling, and no numbness at the end of it. These are our challenges when we're doing an operation. So where are we today? 14% of our patients are dissatisfied. So we can say 86% of them are happy, but you don't want to be part of this 14%. And we need to improve ourselves by focusing on this. TKA has an infection rate. Every patient asks you this. It's 1 to 2.2%. But going by the rate at which we are doing joint replacement surgeries, in numbers, this is quite high. There are medical, social, and legal issues. 30%. So we may say only X had a revision. But remember, 30% of those who failed decided not to go for a revision. True in India because of economic and social reasons. So what is patient satisfaction? So fulfillment of expectations is satisfaction with TKR is primarily determined by patient's expectations and not their absolute levels of function. So you may see full range of motion, I put my implant perfectly, but if the patient is not happy, sorry, it's a failed case. So there are 10 questions according to this wonderful paper. Always take an extended history in the patient. Try to analyze the type of pain, the character of pain, like we've been taught in S. Das and various books. Explore the psychological aspects of the patient. You should get clues while you talk to them. Examine your patients well. There are infiltration tests, so you can get local anesthetics, infiltrate them in certain areas to see if your pain goes away for mechanical causes. Laboratory tests are available. You can do a joint aspiration, a radiographic analysis, and special imaging techniques. So you follow this 10 rule. Of course, before jumping into any operation, I always tell even the fellows working with me, don't ridicule the other surgeon, maybe he's better than you. Try to figure out what you can do better before you jump into doing a revision operation. So before and after TKA, always ask the patient any previous surgeries or any complications he has had, any comorbidities, this may influence your results. What type of implant has been used, CR, PS, whatever. And what is his expectations? What kind of a social life, recreational life, and psychological expectations he has out of this operation? So pain. First question, since when did you have pain? This could give you some clue as to the etiology of the problem. So day one, has your pain started? It could mean something, overstuffing. First few weeks after it, think about infection. Much later, aseptic loosening. So then where is your pain? That's the question. Is it throughout the knee? If it's throughout the knee, in all probability, you've oversized it, there's overstuffing in the patellofemoral compartment or infection. Specific locations, like the tibial plate. So you have to be very particular so that it's seated correctly because there are soft tissues around it. If you overhang on either side, it could irritate them. You could have cutaneous neuromas also that could cause these kind of pains. So is it pain at night and rest? It could give an indication that it is infection, neurogenic, or overstuffing. If there's a starting pain, think about loose components. You've not balanced your knee properly. Pain while weight bearing, it could be a mechanical problem or infection. Pain on full extension, anterior impingement or posterior tightness and extension mismatch. If it's pain on full flexion, posterior impingement, patellar impingement, or malrotation. And pain on descending stairs, most likely to be a flexion gap instability. Ask for associated symptoms, any constitutional symptoms like consider infection, systemic diseases, extra-articular pain, pain away from the knee joint. Think about low backache, hip pain, or radiating pain. And if it's disproportionate, sometimes you feel you've done everything right. This should be your last diagnosis, but think about CRPS. It is a reality, complex regional pain syndrome. think about it if you've tried everything and you've still not come to a decision. So you could broadly classify pain into extrinsic, that is away from the knee joint, or intrinsic. Intrinsic can be further classified into mechanical pain and functional pain. Now, let's look at some standard mechanical causes of pain. So we have these two types of implants, PS and CR, and there's a prolonging debate on the same, which is better or which is worse. Now, each has their place. Now, CR implants have certain inherent advantages that are very appealing to us, but the operation has to be done well. So preserving the PCL, what it does is it basically preserves something called the femoral rollback. Now, when you preserve your PCL, and if your joint line is not correct, then what it could cause is excessive PCL tightness, which overall leads to some kind of posterior impingement and tibial overloading. So very important to recognize this. Maintain your joint line in every CR case. Second, you're using a CR case, your PCL is questionable. What can happen? Your tibia may translate more posteriorly and cause instability ultimately. So be very careful, identify it on table, and if required, go to a more constrained PS implant. Now, rotation is something which is very important when you put your femoral component. So, ideally speaking, we need to be parallel to our tibial base plate. Now, if you put your femoral component into excessive internal rotation, what it does is it alters your patellofemoral biomechanics, there's maltracking, and eventually pain in the patellofemoral region. Now, you can have instability. You can have instability in the sagittal plane, which could cause pain. Why does this pain happen? It usually happens later due to synovitis, debris formation. Or it could be coronal instability. Remember, when you put your implant in, if your components are in excessive varus valgus, there could be eventual collapse in that direction, causing pain. In PS implants, you have the patellar clunk syndrome, where a bunch of synovial tissue forms behind the quadriceps tendon, which basically is in the notch on flexion, but as you extend it, it suddenly dislodges and causes pain. Your popliteus tendon is a very important and neglected part in a knee replacement. It goes from posterior medial on the tibia to the lateral aspect of the femoral condyle. Now, if you do not place your tibial component correctly and you oversize it on the posterolateral aspect and cause overhang, it could irritate your popliteus tendon and eventually cause pain. If you do not position your tibial implant properly in the coronal plane and overhang more medially, it could irritate your MCL. So if you want to err on the side, you may have a little overhang laterally but never have an overhang on the medial aspect. You may oversize your femur. So if you put a size 5 and then you put a size 4, you can see when you're using anteroposterior, or depending on whether it's anterior referencing, posterior referencing, you could alter patellofemoral biomechanics. Here you can see how a size 5, the patellofemoral space is so little, size 4, it increases. Same thing with cutting your patella. If you leave too much patellar bone back as compared to an ideal amount of 15 millimeters, again you can cause overstuffing in the patellofemoral compartment. Also do a psychological analysis. Pain greater than 6 months is chronic pain. You need counseling. Clinical examination, check for stability, swelling, skin condition, selective tenderness, spine, hip, ankle. Infiltration is if you can suspect some kind of bursitis, you can inject a local anesthetic in that region and see if the patient improves. Do laboratory tests like ESR, CRP, IL-6. The best evidence for this is CRP and IL-6 together for infection, and dermatological tests for allergies. Aspiration should be done in an aseptic environment. Stop antibiotics for at least 2 weeks. And these at least 3 aspirations should be done, and possible arthroscopic biopsy before any kind of revision surgery. Radiologically, do a standing scanogram. Very important to check your overall alignment. Merchant view to see your patellar biomechanics, not a skyline view. Contralateral x-rays and pre-op x-rays. Stress x-rays and fluoroscopic views on table. Special imagings like bone scan, CT scan should be done. These are factors that can cause pain. And the next part of my lecture is factors to prevent infection. Just a short slide. Remember hypothermia, core temperature less than 2 degrees centigrade in the OT increases the chances of infection. Surgical site antisepsis, what should I use to clean? Best evidence is chlorhexidine plus isopropyl alcohol. Surgical wound wash, what should you use? Povidone iodine wash, best results with it. Suture material, does it make a difference? Triclosan coated and non-braided sutures should be used, least chances of infection. HEPA filters, there's no evidence established yet. Space suits, unfortunately not established yet. Blood transfusions, yes, more the blood transfusions, more the chances of infection. So limit your blood transfusions if you can. Laminar flow, again, there is no evidence to establish that it helps or doesn't help at the end of the day. So how do we summarize? Look beyond the knee. Remember, everything need not be coming from the knee. Don't neglect the knee. That means focus on examining properly the knee also. Investigate your patient thoroughly. Blood transfusions, surgical site antisepsis, the sutures that you use and wash have a definitive role in preventing infection. Thank you.
Any question from audience? So Vikram, very nice presentation. So how often you go for these radio frequency genicular block for this chronic pain? Sometimes you have very resistant type of pain there,
Right.
not responding to lignocaine also.
Right. Yeah, so I do that with a lot of them these days, especially these, not post-knee replacement, a lot of these osteoarthritic pains that you've tried everything, gone to your pain specialist and you're not able to do it. So I get my anesthetist to give ultrasound-guided genicular nerve blocks, and trust me, it actually helps many times. So I'm a proponent of it these days, if you ask me, only for the last 5 to 6 months, and I've seen some good results in those patients whose expectations are already quite low. That means they've tried everything else, they want an improvement. There may be a placebo part of it, but it does have a strong scientific evidence to at least reduce pain in certain circumstances.
Thank you. So now I would like to invite our next speaker, Dr. Arvind Gupta.
Dr. Amit Gunjan sir, kindly join the chair, sir. Your name was missing, sir. Kindly
Dr.
join the
Amit,
chair, sir.
please.
Dr. Amit Gunjan sir.
Dr. Arvind Gupta.
Thank you, AMC, for the invitation. There is nothing to disclose. So, aim of this lecture is to understand the common classification, understand when to do open reduction and internal fixation of this periprosthetic fracture and how to do, and if there is has to revise the stem or cup, then when it is to be removed. As the incidence of total hip replacement is increasing, so periprosthetic around the hip is also increasing, and its incidence is 0.4 to 6%, and it increases with the revision surgeries. Those who are obese having high chances of periprosthetic fracture, elderly patient with osteoporotic bone, and the incidence with the cementless is higher in comparison to the cemented one. So we should focus on the prevention of this periprosthetic fracture around the hip, and this should start with the basic of total hip replacement, that is the templating. That is the first thing we do with total hip replacement. So templating should be done so that any oversize over the templating should not be done intraoperatively. In this way we can prevent the periprosthetic fracture. At the same time, 360-degree view exposure of the acetabulum, because if acetabulum is exposed partially, and if anything that is eccentric impaction of the implant, that will lead to the periprosthetic fracture on the acetabulum. At the same time, osteoporotic bone with rheumatoid arthritis, like this patient, she was rheumatoid with very severe osteoporosis. In this case, if you try cementless one, the very high chances of periprosthetic fracture. So this was treated with the cemented total hip replacement. The classification, there is intra-op classification, intra-op fracture and the post-op fracture both. Intra-op in acetabulum fracture incidence is 0.2% for the cemented one and the 0.4% for the cementless. And the most of the time it's associated with the acetabular component impaction. And when you are using size more than 2 mm than the last reamer, then the chances is high. Also if you are using the elliptical modular cup, then chances is high. And also those who are osteoporotic, dysplastic hip, and patient has taken radiation therapy around the hip joint for some kind of tumor. And this is the classification for intraoperative fracture of the acetabulum periprosthetic fracture. So treatment depend upon the stability of implant, how stable it is. If it is stable, then we should observe it, protected weight bearing for 2 to 3 months. If it is unstable, your implant is unstable, then you should do the open reduction and internal fixation, or you can increase the size of the cup with additional screw fixation. Next, the post-op femur fracture. It may be around the trochanter, maybe around the stem or just below the stem, and then a type C, that is distal to the stem. So what thing we should consider in post-op periprosthetic fracture? About the stability of the implant, how the basic implant is stable, whether it is located, and what is the quality of the bone, that is a most important thing. So type A, if it is greater trochanter, then AZ. If it is lesser trochanter, then AL. B1 is fracture around the prosthesis or just below it, but stem is well fixed. B2, stem is loose. And B3, stem is loose, at the same time bone is highly comminuted or very osteoporotic, that is the B3. And C, fracture well below the stem. So what should be the treatment goal in such type of cases? The priority should be the fracture union, limb should be anatomically aligned, prosthesis should be stable, and early mobilization with return to the previous function. So if it is fracture of the greater trochanter and fracture is undisplaced, we can manage it conservatively. If it is displaced or there is abductor dysfunction is there, management can be done with the trochanteric plate or cerclage wiring. We mostly do with cerclage wiring. If type A associated with osteolysis, so fracture as well as osteolysis is there, in such type of cases, revision of implant along with the fixation of fracture should be done. If there is lesser trochanter fracture, again if undisplaced, should be treated conservatively. If it affects the stability of the implant, then the cerclage wiring should be done. Like in this case, greater and lesser trochanter was there, cerclage wiring was done for both the things. B1, the implant is stable, fracture around the stem or just below it. So usually treated with the open reduction internal fixation with the long plate, and focus should be over the proximal fixation. Like in this case, the seven screws was used and couple of the screws was bicortical. Graft is debatable, whether we should use a graft or not, it is the point of debate. B2 fracture, the stem is loose, but the bone stock is good. The fracture is at the level of a stem or just below it. Like this case, the bipolar with periprosthetic fracture B2, the bone was good, but the stem was loose. So treatment is the revision of a stem as well as fixation of the fracture. Like in this case, uncemented long stem was used and the fracture was fixed with cerclage wiring. Next is the B3, the more complex one. The implant is loose the bone stock is poor or it's highly comminuted. So treatment is the revision of the stem with fixation, or there is proximal femoral replacement when it is not salvageable. Like this case, having B3 type of periprosthetic fracture, implant is loose, comminuted bone is there. So in this case, you measure the shortening from the level of GT to the center of the rotation on the normal side, then the affected side. Then you calculate the shortening over the trochanteric level. Then you template the implant what you are going to use, which stem is going to fix in the distal part, and also from the tip of the distal fragment to the tip